That's the reason कि
सारे
मैंने
इसको
especially
so we don't give
that's
that
हाँ
to them directly.
right. That's the reason I send only especially.
I think yes, again he's joined there. Anji, all set? Yeah, all set, sir. Rajan, should we start?
Yes, sir.
हाँ वो लॉगिन किया मैंने. ठीक है सर, लॉगिन करेंगे फिर we'll start. ठीक है, मैंने वो कर दिया, वो बना दिया इंट्रोडक्शन वाला. ठीक है, ठीक है. An opportunity to Dr.
Very good evening, sir. We are from Kepler Healthcare. We both are from Kepler.
Good evening, sir.
Hi, good evening.
Yeah, good evening, sir.
Yeah, hi. So I think if everyone is there, then we can start.
Okay. Ashuji,
Yes, sir. Yes, sir. We are on live now.
tell us when we are live.
Yes. We are live.
Live?
Yes, sir. We are live.
Okay. So it's 7:55. I think we can start.
Yes, sure.
Okay. So we'll start. So very good evening to everyone that is listening. I first of all welcome all of you to this interesting session on dapagliflozin by none other than Dr. Kamal Sharma. I welcome everyone, all the panelists, all the participants, everyone. And I also welcome Dr. Kamal Sharma. I hope that everyone that is listening to us is safe and sound as we are battling a pandemic still. When I talk about this session, I think let me first take the opportunity in introducing our speaker, Dr. Kamal Sharma. So Dr. Kamal Sharma, he's an MD, DM in cardiology. I think those people that know him, they know that, he is a big name in interventional cardiology. He has a vast experience of coronary angioplasty, stenting, valvuloplasty, pacemakers, and pediatric interventions. He has a rare combination of a DNB degree in both medicine as well as cardiology. Sir, apart from practicing at the SAL hospital, UN Mehta Institute of Cardiology, Ahmedabad, he practices, and he's also been teaching the subject of cardiology at the BJ Medical College. He has been awarded 22 gold medals for academic excellence during medical studies. He did the world's first vagal nerve stimulation device implant as part of the Anthem study in refractory heart failure. He has also discovered winking coronary sign, or VSR, on angiography, also called Kamal Sharma sign of VSR. We are proud to have him with us today. He's also been the principal investigator in trials like Paradigm HF, Atlas TIMI, TIPS, Seraphim, Canvas, etc. He has been publishing, a lot of articles, a lot of journals, and has 188 publications and more than 7,000 Google Scholar citations. He has been awarded Excellence in Teacher Award by Gujarat University, only cardiologist that has cleared civil services in first attempt, author of 8 books and many chapters. Sir, we welcome you on behalf of Curis Mankind Specialities, and we hope that you enlighten us with your insightful talk on dapagliflozin. Thank you so much, sir, for connecting today. So over to you.
Good evening. Thank you, Ritesh, for that lucid introduction. I'm going to talk about dapagliflozin, and is my screen visible?
Yes, sir. Perfectly visible. Yes, sir.
Perfect. So thank you for having me. I'm going to talk about dapagliflozin as a therapy, not only as an anti-diabetic, but also we look at its cardiovascular and CV safety, superiority, and outcomes, including heart failure. Primarily, we all know the overview is going to be based on the therapy for the Asian diabetics. And we are going to look at the diabetic onset being younger in Indians. We all know compared to South Asians, again, compared to the compared to the Caucasians, they develop diabetes, but with lower BMI, they have generally poor beta cell function, higher CV risk, sustained, hence benefits from the SGLT2 would have sustained long-term data availability, less hypoglycemia, reduction in visceral fat and abdominal circumference, insulin-independent action, and SGLT2 associated weight reduction, and BP and lipid improvements, which can modify all the 3 risk factors, hence improve the CV outcome. And we all know that the novel insulin-independent approach of glucose excretion by the proximal tubule causing glycosuria by the dapagliflozin by inhibiting SGLT2 is selectively PCT-mediated mechanism, and as more amount of glycosuria leads to increased urinary excretion of excreted glucose, almost amounting to 70 grams per day, which is like 280 kilocalories in a day. The benefits hence are unique for the mechanisms, which is providing significant A1C reduction, but because of loss of calories in the urine, patient loses weight, and this also drains out a lot of amount of calorie, brings out weight loss, and also reduction in blood pressure. So this works regardless of beta cell function and complements the insulin-independent mechanisms. Its action is complementing the insulin-dependent pathways that you can modulate in other therapies. Also, because of a renal threshold being achieved at 70 or 90 in these patients, a patient will not lose any more glucose from their kidney if they were to develop hypoglycemia. So if the sugar starts dropping, the drug stops acting. So phase 3 trial for the clinical development included that for monotherapy, combination, comparator studies, and special studies. Monotherapy and low-dose studies were of 840 patients. The combinations had with metformin, SU, Pios, or pioglitazone, or with insulin. Comparator studies included those with metformin, combination with 5 with metformin, extended release, and 10 with metformin. While DEXA, body composition, and moderate renal impairment were some special subgroup studies. Now, there have been consistent A1C reduction at 24 weeks. In these patients, you can see reduction ranging almost up to 1% of A1C. And when you have a DAPA with metformin with SU at baseline, again, the placebo versus the combination of DAPA metformin SU with the same baseline A1C, the reduction was more as compared to those on metformin SU alone, almost by. DAPA is in working in patients who are not controlled even on SU metformin already being given. Again, we can see the consistent decrease in fasting glucose in various studies, decreasing from the range of 20 to 30. And there is also significant waist loss ranging up to 3 kgs in monotherapy. And when you combine it with metformin, again, it's almost the same. for the baseline of 85. But when you add on to SU, which are known to cause actually weight gain, this therapy when added will cause again a significant amount of weight loss. Again, comparing A1C reduction, these are very well sustained over time. Primary endpoint at 24 weeks, when you see there is 0.8% difference between the placebo metformin versus dapagliflozin metformin combination. And these are comparable reduction with SU at 1 year. So you can see that the dapa metformin versus glipizide metformin combination, the A1C reduction were almost the same at the end of a year. Again, reduction in A1C with dapagliflozin were sustained over 104 weeks. You can see that there is overlap at the primary endpoint of 52 weeks. And then when you look at the beyond that, again, there was no significant difference. Also, more importantly, there was very little incidence of hypoglycemia, 40% in SU with metformin arm. Compare this with DAPA, which is almost 3% or less, which is statistically very much significant. Also, the weight loss, that is additional benefit of this therapy, and the difference between the two of almost 1 to 1.5 kg gained in patients on SU with metformin. Here you have almost 3.7 kg loss. So there is a difference of almost 5 kgs in this subgroup of patients. Again, sustained A1C reduction of 48 weeks in patients is noted in add-on to insulin. So even if patient is on insulin, when you combine with DAPA, the weight loss is again in the mean range of A1C of 8.5, and also it has the increase mitigating the need of further requirement of insulin at 48 weeks. So patient already on insulin, you'll have to up titrate. If you add DAPA, you may not have to up titrate. Again, there is a significant argument in favor of dapagliflozin for the effect that it achieves in CV reduction being driven by reduction in blood pressure in both the patients in systolic and diastolic being 4 to 2. And as you know, in our Scott trial, this difference was significant for outcomes between the two arms in a Scott plot trial. So even that, if 2 to 3 millimeter difference between the two trials of ACE with the diuretic versus beta blocker versus CCB arm comparison, people had argued that this difference actually led to the improvement in the CV outcomes. Maybe this difference is contributing to the CV benefits that are seen in this therapy. Again, consistent decrease in A1C from baseline at 24 is seen across the class, whether you use it as monotherapy or you combine with any of the other therapies. Again, the reduction in A1C is in patients who have A1C baseline more than 9. You can see that the higher the base it is from the baseline, more is the A1C reduced, almost 2% if the patient were having A1C more than 9. So more is the uncontrolled sugar, more is the likely benefit that you achieve with dapagliflozin. It's a convenient once-a-day tablet. That's the biggest advantage. And in patients with hepatic impairment, you can start with 5 milligrams. And if tolerated, you can go to 10. Any time of the day, regardless of the meal, it can be given, and there is no food interaction. Only worry that people sometimes used to talk about was mild genital infection, which is measurable. Patient can ask to be drinking a lot of water, urinate often, and take proper wiping of the local parts that can prevent genital mycotic infection. There is increased risk of hypoglycemia when combined with SU and insulin. But remember that these are driven not by SGLT2, but by the hypoglycemic effects of the other two drugs. In rare cases, euglycemic ketosis has been talked about. But again, it's a sick day rules when you employ considering ketoacidosis in patients with type 1, type 2, and low C-peptide or LADA pancreatic. These are the only subgroup which can predispose to it. Increased risk of limb amputation, which was observed with canagliflozin, is not found with dapagliflozin. And rare is Fourier's gangrene. There have been cases reported, but this is once you suspect, it should be discontinued and prompt treatment should be instituted. So contraindication is not approved use in type 1, drug hypersensitivity, dialysis, or lactation. So these are the only group which is very, very rare. Otherwise, everybody you should be using it. DAPA, you can use up to 30 GFR. AMPA, you can use up to 20 GFR. Pregnancy, mycotic genital infection, you should be cautious. So should be cautious in ketoacidosis, acute kidney injury, urosepsis, necrotizing fasciitis, or Fourier's gangrene, as we know. These are only some of the important cautions that you need to be monitoring for. So volume intake and eGFR should be monitored when initiating SGLT in these patients because they have diuretics. When you give, they can have additional problem with the diuretic action. and loop diuretic before that can increase the risk of hydration depletion. So special attention should be given to volume intake when an SGLT2 is co-administered. An initial fall in GFR may occur upon treatment with an SGLT2. So to minimize the risk of adverse event with sick days, you should ask the patient to be monitored quickly with to keep a close record of blood pressure, also keeping their diabetes medication under control, and you have to stop taking SGLT2 metformin GLP-1 if they are not able to drink or eat. SGLT2 inhibitors are efficacious glucose monitoring, lowering medications with established safety profile in type 2 diabetes. They reduce effectively blood glucose and generally are mild and well manageable side effects with severe adverse events very rarely observed. So when you compare amongst the three class, you can see that the improvement with the thiazolidinediones of EMPA, and DAPA, you can see that the A1C reduction along with the thiazolidinediones is in type 2 in patients with type 2 diabetes. A1C reduction is 0.84 with dapagliflozin. Weight is actually lost slightly more with Cana, but again, this is not statistically different. And systolic blood pressure is reduced most by DAPA, and diastolic was almost the same. Now let's come to a very specific subgroup of DAPA in heart failure. We all know that ASCVD, type 2 diabetes, and CKD, all of them are major contributor for the burden of CV disease in type 2 diabetes. So 1 in 3 patients of type 2 diabetes have CV disease, 2 to 5-fold higher risk of heart failure in them, and it's a leading cause of mortality. Diabetes alone is associated with 6 years reduction in life expectancy, and 2/3 of the patients with heart failure also have CKD. So reduced kidney function is associated also with high risk of CV death. So presence of CKD in presence of heart failure increases mortality by 25%. CKD affects up to 40% of type 2 diabetes, and diabetes and hypertension is caused in more than 80% of end-stage CKD. Life expectancy, as it is said, at 60 years by type 2 diabetes goes down by 5.7 years, type 2 diabetes with CKD by 9 years, and type 2 diabetes with MI by 11 years. So diabetes who have previous MI or stroke have much higher risk of death, and heart failure without type 2 diabetes expectancy is 4.6 years as a median survival, and with heart failure with type 2 diabetes, it comes down to 3.5 years as a median survival. So the target of multifactorial management of CV risk factor in established care or standard of care with type 2 diabetes hence would include not only glucose control to bring it down below 7 A1C, along with the therapies which reduce CV outcome, but also lowering blood pressure to less than 130/80 in high risk group, and LDL below 70 in high risk, and individualizing the care including weight loss and optimization. So we know now that from the safety trials that the muraglitazar was withdrawn because of increased CV risk FDA assessment, and rosiglitazone was withdrawn for the increased risk of heart failure and death and MI. And then came the accord, and that's why the new guidelines talked about CV superiority of the trial of the molecules. Now we know from metformin, UKPDS, it provides some evidence of CV benefit of metformin in obesity. Sulfonylurea in UKPDS did not show, UKPDS 33 did not show any deleterious effect versus insulin or conventional therapy. Well, meta-analysis of the smaller trial suggested consistent association of death and all-cause mortality. Carolina, Toscaiti have shown incidence of CV events similar to SU compared to glitazones, and new CVOT trial following FDA approved supported CV safety of glimepiride. The CV safety of most of SUs has not been established in long-term outcome. Meta-analysis suggests it may have a heterogeneous effect. So some SUs are detrimental, some are not. Now, looking at the other alternative of thiazolidinediones, you can see that the significant reduction in 3-point MACE was found in proactive trial in glitazone, and significant increase was of heart failure was found with Rossi record. So meta-analysis clearly talks about increased risk of MI with rosiglitazone, and increased risk of MI led to the withdrawal of Rossi from the market. So differing CV outcome hence emphasize the need for combined to increase the need for the compound within the same class of demonstrator of CV superiority. So CVOTs are required to evaluate CV safety and new glucose lowering therapy. So CVOT trials hence were designed to look at the important CV analyzed high-risk population group, and long-term data is required in them with prospective adjudication on top of that. So you have meta-analysis of phase 2 and 3 designed to permit meta-analysis safety events of completion. FDA guidelines for CV risk evaluation has talked about upper bound, which talks about CV superiority and non-inferiority. So extended MACE in the pre-marketing risk assessment to exclude the upper limit of confidence interval has gone up to 1.8 times for because it allows a more reasonable sample size for evaluation. For long term, more reassuring of CV safety for post-marketing would be exclusion of 95% confidence interval of more than 1.3 on 3-point MACE. So if you have a risk up to 1.8, then beyond 1.8, it's inadequate data to support. If overall risk benefit analysis supports approval, PMS would allow CVOT to be proving less than 1.3, and 1.3 was the allowed limit for the CV safety. So prevalence of heart failure is projected to increase in US from 5.7 million in 2012. More than 8 million are anticipated because of aging population, emerging therapies that improve outcome and survival, and increasing prevalence of contributory factor for heart failure. So definition of heart failure, as we know, has now been changing. Ejection fraction is the amount of the blood pumped out of the ventricle versus the total amount of blood in the ventricle. Heart failure is a complex disorder as defined by American Heart Association and ACCF, which talks about either diastolic or stiffened ventricles, or systolic, which is a weakened muscle. So you have reduced ejection fraction or preserved ejection fraction. So once there is initiation and perpetuation of heart failure, the reduced organ perfusion will cause activation of neurohormonal pathways, leading to worsening pressure and volume overload with progressive symptom and remodeling, causing further worsening and hence a vicious cycle. When you look at the contractility, preload of stroke load and cardiac output, all is determined by preload, afterload, and valve competence with heart rate. Three common surrogate markers, hence, for the contractility would be dP by dt, left ventricular ejection fraction, and also SET. So SET, which is basically looking at the systolic ejection time, is a parameter for it. So heart failure with reduced ejection fraction and preserved is defined by less than 40% versus more than 50%, where you have concentric versus eccentric modeling, LV mass to volume ratio, systolic function being preserved or not, younger versus older patient, and risk factor being common pretty much in the all. So as the heart failure ensues, there is a gradual decline with of the acute episodes causing worsening over a period of time. So repeated multiple hospitalizations are common in both the subgroups over a 5 period of follow-up, with more than 80% with either type of heart failure requiring hospitalization with high early after discharge, with remaining elevated risk of 20% of the patients being re-hospitalized within 1 month, and more than 55% within a year. So many patients who are discharged with unresolved congestion, which is associated with long-term poor prognosis, vicious cycle of heart failure, can have 55% patients getting readmission in them. So once the LV dysfunction is there, you have RAS activation, sympathetic nervous system activation, and blunted naltrexone pathway system action. Also, on top of that, you will have reduced contractility, and all of them have been targeted at various levels by preventive action, or ACE-ARB, MRA, or beta blockers, and ARNI and inotropes in these situations. Now, lifestyle change, weight loss, smoking cessation, low sodium diet, exercise training, cardiac rehab, medication adherence, etc., is also an important parameter for heart failure reduced ejection fraction as an etiology. Guideline-directed heart failure therapy like RAS, beta blockade, MRA, ivabradine, hydrolysine, isosorbide dinitrate, diuretic, digoxin have also been used, and devices include CRT, ICD, transplantation, etc. So we all know that if there are no events, the mortality is 14%. But then you have intensification of treatment, 32% will have all-cause mortality after first ever event. And as this goes up, whether you have emergency department or heart failure hospitalization, the event tend to be almost in 1/3. Management of heart failure, reduced ejection fraction in multifactorial, as I mentioned. We can't cure heart failure. You can just actually try to improve. And we know that from Paradigm HF, that 30% of the patients with reduced ejection fraction or mild symptom experience some manifestation worsening within 3 years. So it is said that the therapy actually improved the survival by almost 2 years. So two major modes of death were sudden death or worsening of heart failure, and both were reduced when you added ARNI. But on top of that, when you have a diabetic patient and you add then the SGLT2, you prevent heart failure and renal outcomes, but also prevent heart failure deaths. So the serendipitous story of SGLT2 in heart failure was published in Declare CME by Subodh Verma et al., which talked about how the worsening of heart failure and death with or without diabetes was documented in DAPA-HF. So when you look at DAPA-HF background, they started treating patients to prevent worsening of development of heart failure in type 2 diabetes, with or without diabetes, whether it works or not. And you can see that both the groups, diabetic versus non-diabetic, were pretty much matched, and they were all on optimal therapies like diuretics, ACE, ARB, and a lot of patients were on ARNI. You can see almost 11%. Beta blockers were almost there. So 3/4 patients at MR, and more importantly, almost 1/4 patient had an ICD already in place. So outcomes were not very different. In diabetic also of 25% reduction, and non-diabetic also 27% reduction of the composite endpoint of CV death, hospitalization, urgent visit. And more importantly, cardiovascular death itself was significantly reduced as an important parameter in both the subgroups by 15% and 21%. Again, worsening of heart failure was reduced by 23% and 38%. In secondary outcomes, in order of hierarchy, they could show that the CV death of heart failure hospitalization was also reduced by 25%, and total hospitalization in CV death also being reduced. So meaningful quality life improvement was there both in diabetic and non-diabetic subgroup by 22% and 12%, and worsening of renal endpoint was also reduced, which was a composite of worsening of 50% plus of EGFR or end-stage disease or renal death, was also reduced significantly in both the subgroups. So according to A1C, whether you had a higher A1C or a lower A1C, in both the patient subgroups, the dapagliflozin was better, whether you had diabetes or not, or your A1C was lower or higher. And the outcome, when you look, the continuous hazards ratio for a unity of 1 for primary endpoint and CV death, it was for all patients a good drug. And when you look at safety also, the volume depletion, whether you were diabetic or non-diabetic, or renal outcome, or fracture, or amputation, or hypoglycemia, was absolutely same like placebo. So that's fantastic. You don't have any side effects that you experience in Declare CME, and you had, irrespective of diabetes or non-diabetics, there is absolute as well as relative risk reduction of death, hospitalization, and clinically important in both the subgroups, with dapagliflozin offering a new treatment approach for heart failure. So US FDA had fast-tracked the approval of this therapy. Looking at the DAPA-HF renal outcomes, when you see more than 50% sustained decline of EGFR and renal death was found in both the subgroup, and DAPA-HF change in EGFR, you can see, was of 1.7 per ml per meter per minute, 1.73 meters square. From day 14 to day 70, you can see that initial phase, of course, there is slight fluctuation, but later on, DAPA preserves kidney function much better, and the doubling of serum creatinine was significantly reduced by 34% over a period of time in diabetes. So diabetes prevention is those without diabetes at baseline is also important. So diabetes, new development of diabetes was prevented in patients who were given dapagliflozin by 32%. DAPA-HF pre-specified subgroup clearly shows that across the geographic area, including Asia, or the Asian ethnicity, or the age group, or the gender, or the mean BNP, IMRA, or whatever drug you are using for the etiology, it worked across the class. So according to age also, there is significant benefit, death-wise, heart failure, hospitalization outcome, or renal safety according to age also. There is a significant benefit for renal adverse events, serious adverse events, or even more doubling of creatinine. So this is the another article in Circulation from efficacy in heart failure with reduced ejection fraction, and exploratory subgroup looked what happened if the patient was already on ARNI or not. And when you compare ARNI versus no ARNI post hoc key points, you can see that again across the class it benefited on top of it. Again, selected pre-specified group of change in NT-proBNP from baseline, you can see that there is a difference of 303 picogram per ml difference at 8 months in terms of improvement, not rising of the serum of the NT-proBNP in these patients. Again, expanded composite, hence for the outpatient patients of heart failure worsening in paradigm, even with episodes of worsening of heart failure, with increased oral therapy in ambulatory setting were associated with poor prognosis. Prospective collection of DAPA-HF episodes of worsening not requiring IV therapy or admission to hospital, and expanded composite endpoint of any non-fatal or fatal manifestation would be some expanded endpoint. So when you look at that, 27% reduction again compared to placebo for CV death, heart failure, hospitalization, or an outpatient worsening. So whichever way you modify the definition or the outcomes and try to compare them, you can see that the benefits were there, including urgent need for a heart failure hospitalization. So that is an important parameter. You're an outpatient, when you prescribe, you actually prevent the new heart failure hospitalization or need for the visit by the patient. And these benefits are consistent across the risk continuum. Whichever way you look, the blue line is always on this side by a magic risk score. So DAPA-HF results in a rigorous practice-changing paradigm shift, large trial with multi-centric, multi-country, persuasive p-value, large effect size, mortality reduction, improvement in quality life, safe, and similar benefit without diabetes. And there is an exploratory data which looks at the primary outcome when it becomes statistically significant. First 100 days also, the point was significant at 28 days with a 49% reduction for the composite endpoint. Again, you may actually end up not comparing the two, but DAPA-HF versus AMPA-reduced, the most striking feature is the all-cause mortality. The mortality is not reduced in AMPA-reduced, but it's reduced by DAPA-HF by 17%. So nothing matters more than death. CV death also reduced, no difference in AMPA-reduced. So it's like turning the table by DAPA on AMPA in heart failure compared to say AMPA-REG and declaratively. You have heart failure hospitalization and total hospitalization for heart failure reduced significantly in both, but the CV death in patients with prior MI, though, was reduced more in AMPA-reduced, but all-cause death and CV death were more reduced with DAPA-HF, with the composite renal endpoint, sustained decline of eGFR being present more significantly in DAPA-HF also. So DAPA-HF is a momentous victory won against heart failure. You can see that the Canvas, Declare, and AMPA-REG were the programs that were looking primarily at the preclinical and clinical stage. DAPA-HF looks at the heart failure, and there are some more trials like Deliver Heart Failure Preserved and Solo is to WHF AMPA-reduced, which has just been published. The positive trials includes now DAPA-HF after Paradigm-HF. Now SGLT2 is a new pillar in heart failure with or without diabetes, apart from ACE, ARB, beta blocker, MRA, RNA, and DAPA being the fifth pillar now. So SGLT and cardiorenal protection are beyond these benefits. People talk about increased myocardial energetics and increased beta hydroxybutyrate causing improved myocardial ATP production and utilization. Also decrease in the afterload and preload by natriuretic diuresis can contribute to the same. So diuresis, natriuresis, afterload reduction, energetics, and direct effect on the myocardium are some of the other mechanisms where it can work. All of them are from inhibition of cardiac NAH exchanger, modulation of autophagy and mitophagy, increased production of erythropoietin, reduction in blood pressure, improvement in vascular structure, modulation of cardiac energy metabolism, improvement in cardiovascular function, and reduction in uric acid are some of the other postulated mechanism. And pre-specified subgroup I've already touched upon. Meta-analysis, when you compare and combine both Emperor and DAPA-HF, you can see that again, with or without diabetes, the therapy works. Additional benefits are reduced incidence of new diabetes, reduced NT-proBNP, reduced uric acid, and resolution of anemia because of the erythropoietin secretion, which prevents development of new anemia also. What remains now is the acute heart failure, patients hospitalized with acute heart failure, and heart failure with preserved ejection fraction. Soloist WHF is the primary outcome assessing trial, looking at patients with stratified with 75% of patients though had less than 50% NT-proBNP. And in that also, when you combine that data, death from the cardiovascular, death from all cause, and CV death or total heart failure hospitalization is reduced. Phase 3 morbidity mortality trials of SGLT2 in heart failure talk about DAPA-HF, Emperor rate preserved, and Emperor reduced in the ambulatory subgroup, and hospitalized patient DAPA-ACP, Soloist WHF, and Deliver are looking into it. Adverse and safety event from DAPA-HF are pretty much matching. And ketoacidosis, as you can see in sotagliflozin, was 0.33%, DAPA is only 0.13%, and Emperor reduced to 0. So placebo-controlled changes in the patients with systolic blood pressure, you can see, is reduced more in those overall group, but in the patients whose blood pressure was slightly higher, they lost more blood pressure. If your blood pressure baseline was lower, the blood pressure reduction was lesser. So incidence of hyperkalemia was also prevented. That's the other additional benefit. When you look at the MRA-treated subgroup patients, incidence of hyperkalemia was lower. So where are we in 2021? We talk about moving from neurohormonal modulation from a previous era of heart failure pharmacology, from digitalis in 1785. In 1924, you had diuretics. In 1987, ARB beta blockers came. 2014, sacubitril came. Despite changing guideline recommendation, therapy is not currently optimized. In CHAMP registry, you can see that the guideline-directed therapies, very small patients receive. ARNI is given only to 12% of the patient who have been treated with this. Compare there with beta blockers, only 2/3 patients receive it, and MRA only 1/3 patients receive it. So in patients, as per the guidelines, therapeutic approach with reduced ejection fraction, you should initiate standard therapy with EF less than 40% and symptoms, assess clinical factor for additional intervention, and one's must do is to reduce the mortality with therapies from the eSpace HF slide. That ACE, ARNI, beta blocker, MRA, SGLT2 should be added. CRT for QRS more than 150, ICD for EF less than 35. And to control congestion, loop diuretic at the lowest effective dose should be given with exercise and rehabilitation. You should also consider ivabradine, isosorbate dinitrate with hydralazine in blacks, vericiguat, and omecamtiv mecarbil, which is a myosin activator in patients with EF less than 30%. So vericiguat, omecamtiv mecarbil is going to be available soon. Mitraclip with COAPT criteria, iron, IV, FCM, or TIM-HF with telemonitoring, and cardiomerms for repeat heart failure hospitalization, or some of the other options include digitalis, IV, FCM, and iron deficiency. CCM for QRS less than 130 can also be considered. Phrenic nerve stimulation, Barostim Neo, though not suitable patients for CRT, can also be given this. And for advanced heart failure in selected patients with severe limitation heart transplant and long-term MCS in not suitable subgroup. So patient profiling and tailoring, a consensus document has been published by European Society of Cardiology. The updated consensus statement for the same talks about giving ARNI, ACE, ARB, with ARNI being preferred, and then of course you can keep on adding drugs according to the criteria, whether it's aldosterone antagonist, SGLT2, diuretics, isosorbate dinitrotoluene, or ivabradine. So drugs recommended in all patients hence would be ACE, beta blocker, MRA, and in chronic kidney disease, role of DAPA has been now also been documented for kidney failure rates and mortality. You can see that the number of patients of kidney disease have been increasing worldwide, and die of the other cause without reaching kidney failure, 90% of which half of caused by CV diseases. Across the range of kidney function, you want to preserve ejection fraction, EGFR, with EGFR below 60 versus those more than 60. A proportion of the patient with normal or microalbuminuria can be present across the class. Proposed renoprotective mechanisms for SGLT2 have includes all the criteria that we discussed previously also, and evidence that has emerged from end-stage kidney disease, substantial loss of EGFR or renal death from the baseline has also been looked into. So the credence summary was basically that the end-stage kidney disease, doubling of creatinine or renal or CV death was reduced significantly by 30% in the subgroup, but the secondary outcomes were also improved in credence trial. Rationale for that created the DAPA-CKD trial. Credence had showed CANA reduce the risk of kidney failure and CV outcomes, and hence, despite guideline-directed therapy, CV complications of CKD were high. Hence, the benefit of SGLT2 therapy was to be independent of glucose lowering, and that was the hypothesis of DAPA-CKD trial, which looked at the sustained more than 50% EGFR decline, end-stage kidney disease, renal death, or CV death as the combined endpoint. So patients who are adults with EGFR between 25 to 75 with USCR between 200 to 5,000 with stable maximum tolerated ACRB of more than 4 weeks with or without diabetes were enrolled for dapagliflozin versus placebo to look at the predefined composite endpoint, which I just talked about, with first patient in by 2017, and by 2020 the last patient was out. And you can see that the there was 39% relative risk reduction with DAPA, with more individual components of the composite, of course, reduced, but majority of that came by more than 50% decline in EGFR being reduced significantly. So pre-specified subgroup analysis looks at the dapagliflozin at baseline in type 2 diabetes, not reaching no difference between the two subgroups or even in the USCR group or EGFR group. Across the class, the primary composite endpoint was significantly lower. Statistical significance was achieved for primary as well as all secondary outcomes, especially driven primarily by 50% decline in the EGFR. CKD outcomes, including all-cause mortality from the glomerulonephritis, was reduced significantly. So prevention is always better than cure. And when you give SGLT2 earlier, it's also going to prevent the therapy and its complication. Thank you for patient listening. Over to Chair. If there are questions, I'll be pleased to answer them.
Sir, thank you so much for such an insightful talk. Sir, we'll be taking questions now.
Sure.
Okay. So I'll start with the first question that we have got. Sir, the question is regarding the dosage of dapagliflozin. Like, how do you change the dose of insulins? You know, the question is when you're using it with an SGLT2 inhibitor like dapa. So how do you titrate the dose of insulin?
Yeah, so changing the dose of insulin or other, for that matter, DPP4, any other drug. So DPP4, probably you need not go down. Metformin, again, you need not go down. Insulin and SU, you can go down, you should go down, because if they are euglycemic, then you may. But most of the time, you don't have to go down, because most of these patients are anyway uncontrolled. If the patient is on insulin, you can go down the dose, reducing by 10 to 20 units, and sometimes halving the dose if the dose is lesser than that. That's what usually I do, but there are no clear-cut guidelines to talk about it. But if it's a well-controlled, tightly controlled glycemic control, then of course you can go down on the dose of insulin. For a cardiologist perspective, what we do is we avoid a drug that can cause hypoglycemia. So my preference in a patient who's come with cardiovascular disorders to give SGLT2, add a GLP-1 if he can afford, add metformin. Yeah, if not, then add a DPP4. If he's not heart failure, maybe a low dose of glitazone. Then only comes your other therapies. Then only comes your insulin and SU in a cardiologist chamber. I'm not arguing for a non-cardiovascular patient. I'm not talking about how glimepiride is different from glyclazide or say a glabenclamide. But why would you want a hypoglycemic agent in a cardiovascular patient? Because most of these CV events are being triggered by it. So that's the strategy that we adopt. But if then you have added and patient is tightly controlled, I think it's a subject that you have to cut down on those.
Right, sir. Right. Sir, so just one question I have from my side only. Sir, if you are looking at the dose titration, like you're not you're using these kind of agents, sir, do you feel like GLP-1 and SGLT2 are a complete therapy from a cardiology perspective?
Yeah, absolutely. I mean, I would combine the two. It was the most fantastic, because I've had patients who lost 15 kg with metformin as the third. So yeah, I had a patient with 105 kg came with acute anterior wall MI and prescribed this patient on the therapy, took it off his insulin and SU. We discontinued it. I told my endocrinologist that I'm adding these two. What do you think? He said, no, perfect. I think you should take off SU and insulin if he can be well controlled on these. And he was. He's lost 15 kg and he's doing well. So I think every CV benefit in a patient who's already having secondary indication, you'll have to put these on GLP-1 analogs and SGLT2.
Right. Sir, another question that has come to us is regarding the basically the diuretic dose with an SGLT2 inhibitor. So I think that brings us to the question that is it just another diuretic?
Yeah, I think we have to cut down. That's a good question. So diuretics, you'll have to cut down to half. That's what I usually do. I cut down that to half. So otherwise patients can get into a renal impairment. So it's a good therapy. It's a good diuretic replacement actually if you put the patient on SGLT2. So I cut down that dose of diuretic to half and try to take it off if I can. If patient is class 1 or 2, maybe a DAPA alone or is going to be good enough to take care of class 2 symptom.
Right. A lot of questions, come these days regarding MRA, ERNI, and 3 classes of drugs in a heart failure patient, because again it leads to renal dysfunction, hyperkalemia, all these side effects are there. So sir, how do you use all these 3 in heart failure?
Yes, I do use, and what I do use is that when I'm giving an MRA, I don't give torsemide, I give furosemide. And when I'm giving dapagliflozin, that's the other thing which I showed in my slide. When you give them dapa, the risk of hyperkalemia is lesser with MRA. So if your patient is on MRA and you've given dapa, your risk of developing hyperkalemia is much lesser. So I usually give that combination to them. I put them on MRA. I avoid giving torsemide if the patient is on diuretic. I would get it through furosemide. And then, of course, adding a SGLT2 would also be giving you some amount of leverage onto potassium. Ritesh, are you there? Because I think your screen is frozen. I think we have issues with Ritesh's network. Nirav, can you confirm? I can see you, Nirav. Yes. Nirav, you're muted. You're muted, Nirav.
Yes, sir. I think Ritesh has lost the connectivity, sir.
Yes, yes. So are there any questions that you can see in the chat box?
No, sir, I am not able to see.
Okay.
Right now.
So I think Ritesh is connected back. Yes, Ritesh, we lost you for a while. Any more questions?
Yeah, sir. Yes, I was actually in the middle of listening that one. Okay, so sir, one last question that we have, I think regarding the UTIs. I think SGLT2 inhibitors, the major challenge has been UTI always. So how do you manage a UTI?
How do you manage?
UTIs, urinary tract.
UTIs. So yeah. So I think most of these are mycotic infections, which are primarily better prevented. Ask the patient to drink a lot of water. And after the hydration, proper hydration, if the patient is wiping the local genitals properly and taking a lot of fluid and urinating frequently, I don't think patients get that often recurrent UTI. That's number one. And number two,
Niravji, sir, audible?
No. I think his connectivity has gone.
Connection is.
Yeah.
I think sir is just logging back. We'll
Yeah.
just join.
Let's wait for 1 minute, 1 or 2 minutes. Ritesh, can we conclude?
Yeah.
Yeah, sorry,
Please,
it's back.
sir.
Yes, sorry, it's
Okay.
back.
Yeah,
So
hi. Am I audible and visible?
Yes, sir. Yes, sir.
now you're
Yeah, so networks these days are like diabetes. पता नहीं कब किसको धोखा दे जाए. So
okay. Right.
yeah, so it ditched Ritesh once and then it ditched me. So
Right, sir.
yeah, so I was answering something on UTI. So fluconazole is something that people give for mycotics, but most often what we do is control the sugar levels very well first with other agents and then add an SGLT2 if you have a time. That's one strategy, because more the uncontrolled diabetes, more is the likelihood of having glycosuria. That's the strategy that we use.
Right, sir. Right. So I think, sir, thank you. First of all, I would like to thank you on behalf of Curious Mankind Specialities. I think you really explained very well that how dapagliflozin is not just another, molecule. It's, a wonder drug. And every, cardiologist, physician right now in the country, really wants to prescribe this particular molecule. So I would like to thank you on behalf of Curious Mankind Specialities. And I would now ask Nirav sir to kindly, give the vote of thanks to Dr. Kamal Sharma for giving such an enlightening talk. Nirav sir, over to you.
Thank you very much, sir. It is always a pleasure to listening to you. I know you are the best speaker across Gujarat, especially.
Thank you. Thank you.
One of the best academician in Gujarat, right, sir? So we really appreciate your valuable time and valuable insights on our dapagliflozin brand. And thank you very much to all the attendees and participants for your valuable presence. Recently, we have launched our first time in India dapagliflozin with API DMF grade, which is world-class dapagliflozin with most affordable rates. And our team will soon meet you for the same. Thank you very much for your valuable time.
Thank you. Thank you, everyone. Thank you for having me. Bye-bye.
Thank you so much, sir. Thank you.
Bye. Bye.
Ashuji, we can just now end the meeting. Yeah, you can end the meeting.